Assalamu alaikum everyone. Hope you're all doing fine. Today, inshallah, we're going to discuss one of the important lectures present in the nervous system module. We're going to discuss the pyramidal tracts or the descending motor tracts of the nervous system. By the end of this lecture, you should be able to identify the main components of the motor nervous system, list the functions of the pyramidal and extrapyramidal system. Yes, this is a lecture for the pyramidal tract, but we're going to discuss the functions of both pyramidal and extrapyramidal. And also by the end of this lecture, you should follow the flow of the motor signal from the motor cortex till its destination via the pyramidal tract till we reach the effector organ. The motor pathways that we're going to discuss today, inshallah, they are the descending pathways present in the brain and the spinal cords. These are the pathways taking the motor signals coming from the higher cortical areas towards their effector destination. And in this particular part, we're talking about our muscles, the muscles of the body that are under voluntary control. So these pathways represents the descending pathways present in the brain and the spinal cord, controlling our muscular system and regulating its activity. Earlier in the introduction lecture, we stated that the functions of the nervous system includes sensory input, integration, and execution of a function in response to this integration. The motor tract transmits a motor command in response to a sensory information. Someone is tapping your back, you have to tilt your head to see who's tapping it. Okay, someone called your name, you have to shift your body, to twist your body, to turn to see who's saying your name, who's shouting your name, who's calling your name. Okay, so the motor commands are in response to a sensory information. These motor commands are delivered via two systems. They are either a somatic nervous system, and this somatic nervous system directs the motor commands towards our skeletal muscles, the one under voluntary control, whereas part of this motor functions are delivered via an autonomic nervous system, directed to the activity of the glands, smooth muscles, and cardiac muscles. Okay, this is for the motor commands in general. Okay, we are talking now about the whole motor system of the nervous system. As you see, this is a diagrammatic representation for the central nervous system. This is the brain, cerebellum, brainstem, and spinal cord. Here is the area for the higher centers of the brain, the cortical areas, where the initial motor signal originates. These initial motor signals either pass through the brainstem to reach for muscles present at the face, or completes its pathway till it reaches the spinal cord, where it emerges with the spinal nerves to reach an effector organ, a muscle cell present at the rest of the body. So this is a diagrammatic representation for the motor signal that originates from the brain till it reaches an effector organ. To complete the definition of a motor tract, we have to define or to address two more terms to clarify the whole aspect of a motor system. The first term is called an upper motor neuron. An upper motor neuron is a group of neurons that are entirely within the central nervous system. Entirely means that it begins and it ends within the central nervous system. The word central nervous system includes the brain, the spinal cord, the brain with its subdivisions, cerebral cortex, cerebellum, and brainstem. So any cell that has its origin within the central nervous system and ends within the central nervous system, it's called an upper motor neuron. As we said, it originates in the cerebral cortex, brainstem, and spinal cord, forming a descending tract regulating the lower motor neuron activity. Then I've got another term, a lower motor neuron. Then a motor tract is actually divided into two partitions. An upper motor neuron, this part of the tract is entirely within the central nervous system, and another part of the tract is called a lower motor neuron, where it begins within the central nervous system, either at the brain stem through the cranial nerve nuclei, the ones controlling the cranial nerves that we discussed in the introduction lecture, or the anterior horn cells of the spinal cord. When we discussed also the anatomy of the spinal cord, we've got a cross section at the spinal segment. We saw the gray matter inside, the white matter to the outside. We saw the gray matter in the form of an H shape with an anterior horn that was motor, related to the ventral horn or the ventral ramus or the ventral root, and another posterior horn or dorsal horn related to the posterior root, which was sensory at this instance. Makes up a spinal and cranial nerve that innervates the skeletal muscles. This lower motor neuron, after exiting from the central nervous system, constitutes parts of a spinal or a cranial nerve according to where it originates. If it originates at the brainstem, then it would be one of the cranial nerves. If it originates within the spinal cord, it would be one of the spinal nerves. So a motor tract is formed of two neurons. One neuron is within the central nervous system, starting from the cortical areas or anywhere beneath it within the central nervous system, and it regulates the lower motor neuron. Its cell body is present in the anterior horn cell of the spinal cord or a cranial nerve nuclei, while its action is part of a spinal or a cranial nerve that innervates skeletal muscles. The motor tracts executes their function by delivering the motor signal towards an effector organ through two main systems. A pyramidal or a conscious tract, giving us a conscious control over our skeletal muscles, and an extrapyramidal tract and a subconscious tract, giving us regulation upon these muscles. So one of them gives us control upon the skeletal muscles we use in our movements, in our talking, in our chewing, deglutition. And another part of the system regulates the muscle tone, the balance, the eye, hand, and limb positions during these movements. It gives us a subconscious integrative coordination of muscular activity. So when we talked about the motor tracts, we said that the motor fibers either deliver their signal, or the motor signal delivers its signal through a somatic nervous system towards our skeletal system. This is the one we're talking about now, the pyramidal and the extrapyramidal tracts. An autonomic nervous system directed to the smooth muscles, cardiac muscles, and glands. We also subdivided the motor tracts or the motor fibers going to the somatic nervous system into pyramidal conscious part of the motor tracts that we're going to discuss in this lecture, and an extrapyramidal part that we're going to be discussing in a next one. The pyramidal and the extrapyramidal system can only be separated anatomically, but not functionally. Both cannot work solely or independently from the other part. None of the two systems can work properly alone. They constitute one motor system together. Okay? The pyramidal system is the chief organizer and executor of voluntary movement. The first initial crude motor signals comes through this pyramidal system. While for the extrapyramidal system, it includes all motor centers. I've got other motor centers outside the pyramidal system. The pyramidal system originates from higher cortical centers, but I've got other motor centers regulating the initial impulse coming from the higher cortical ones. These centers and pathways lies outside the pyramidal system and beyond voluntary control. I cannot control it on my own. This extrapyramidal system coordinates movements of various groups of muscles both in space and time. When you move your hand towards a glass of water to grab it, you're aware that you're getting with your hand towards the glass. You're not aware of the muscles being involved in this movement. So the ones that the movement that is under voluntary control is the movement of the whole limb, while the movements of the muscles included in this limb, the muscle groups that are moving and pushing this hand towards the glass of water, this is the work of the extrapyramidal system. It regulates the job and sport-specific automatic movements consisting of periodic elements. Each and every one of you has got his first time with everything. You had your first time riding a bike. You had your first time typing on a laptop. You had your first time driving a car. Remember your first time typing at a laptop? You remember that you were looking to the keyboard. Your eyes are looking for each and every letter, and you're pointing to each letter with your index finger. While with practice, this becomes an automated movement. You do not even look to the keyboard. You're using all your fingers. You're not looking at the keyboard. It's an automated movement, like riding a bike. If you see a small child riding a bike for the first time, you'll see him tumble, you'll see him fall, you see him hit his knee, you'll see him hit his head. 1 or 2 or 3 times when he masters the riding the bike, you'll see that he's riding without his hands. These automated movements is also the job of the extrapyramidal system. It includes walking, running, riding a bike, dancing, driving, and handwriting and typing. The extrapyramidal system controls the emotional movements. Emotional movements means the movements of the muscles of the face for facial expressions. The ones responsible for happiness, for grief, for excitement. These muscles movement is controlled by the extrapyramidal system. It also helps to control posture and balance. If you're moving upon a slippery floor, you're moving somewhere, you're not aware that the floor is slippery, you start sliding on the floor, going to hit your head to the ground. What happens? You have a sudden corrective movements of your body that you might not be aware with. You'll find that your body twists and moves suddenly to try to regain its equilibrium, to prevent you from falling. This happens beyond your conscious control. You find that your body moves on its own. This control for posture and balance is also a function of the extrapyramidal system. And all these functions happen through the regulation of muscle tone. I'm increasing the muscle tone in one muscle to increase its strength and power and stamina, and decreasing or inhibiting the muscle tone of another muscle to relax it and cause it to be still and do not move. This is a schematic representation for the functions of the pyramidal and the extrapyramidal system. It's a very nice picture. As you see, this one shows an outline, for like a palace, like a castle, a big castle. This might be the sky, and this might be, I don't know, might be a garden, might be a ground, might be anything. It's just a sketch. I'm seeing an outlines, but I'm not seeing the whole picture. I'm not seeing the details. I'm not seeing the tip of this tower looks like what. I don't see colors. I don't see anything. It's a mere sketch. Only the principal component can be recognized through the pyramidal system. Whereas for the extrapyramidal system, you can see the colors, the beauty, the harmony, the regulatory part, but not more than an abstract art. Meaning, in this picture, I can see colors. This might be the sky. It's blue, yes. I can see that the palace at the background, I've got a brown color or a, like dark red color. This is brown color. There might be windows in here. I think this is a light, like a blue color, might be a sea. I'm seeing more details, but I'm not seeing the sketch that these details are being plotted upon. When we put the sketch with the details, we have the final picture like this. Okay, so moving through the pyramidal and the extrapyramidal system both happen at the same time to give a desired motion or a desired function. The pyramidal tract, the core of our lecture today, is called a conscious tract. Conscious tract meaning that it's under our voluntary control. Included in this pyramidal tract, 3 pairs of descending tract. Pairs means I've got 2, 1 to each side of the body. These descending tracts are ending directly on lower motor neurons of brainstem and spinal cord. The word lower motor neuron was mentioned earlier when we divide the motor tract into two neurons. One of the neurons is totally confined to the central nervous system, originates and ends within the system, and another cell that originates within the system but ends outside the system, outside the central nervous system, outside the brain, the spinal cord. This pyramidal tract is formed by cells that ends upon the lower motor neuron cells in the brainstem and spinal cord. So it's actually an upper motor neuron cell. The corticobulbar tract or corticonuclear tract and a corticospinal tract. A corticobulbar or corticonuclear is a tract coming from the cortical areas, so it's called cortico, and ending upon the cranial nerve nuclei for the nerves controlling muscles of the head and neck. The muscles of the head and neck are supplied by cranial nerves coming from the brain and the brainstem. They are 12 in number. The part of the pyramidal tract controlling these cranial nerves is called corticonuclear or corticobulbar tract. Whereas for the spinal cord, we've got another system, another tract called anterior and lateral corticospinal tracts, and these form the conscious control over the skeletal muscles of the trunk and limbs. So our pyramidal tract is divided into two parts. One part supplying the head and neck muscles, this is called the corticobulbar or corticonuclear, whereas for the other part supplying the rest of the body, the trunk and limbs, it's called corticospinal. Cortico coming from the cortex going to the spinal cord is called anterior and lateral corticospinal tracts. Whereas for the extrapyramidal system, we've got four other tracts that will be discussed in a separate lecture. They are vestibulospinal, the tectospinal, reticulospinal, and rubrospinal tracts, one coming from the vestibular nucleus, one coming from the tectum of the midbrain, one coming from the reticular formation, and the last one is coming from the red nucleus. The four are called subconscious motor tracts, or else called extrapyramidal tracts or extrapyramidal system. To execute a voluntary movement, we have to pass through a certain circuit to end up with a proper, smooth, decent, purposeful movement. This circuit starts with the cerebral cortex, the primary motor cortex, premotor cortex, and supplementary motor cortex, the areas that gives the initial, crude, clumsy motor signal. These motor signals pass through two other brain parts, the basal ganglia and the cerebellum. The basal ganglia and the cerebellum are responsible for modifying the initial, crude, clumsy signal, meaning that this signal has to be modified. I'm intending to reach up with my hand to reach for a glass of water. The signal coming from the cortex was a weak signal, so when it passes through the basal ganglia or the basal nuclei, the basal nuclei reaches back to the cerebral cortex, enhancing the movement, enhancing the initial weak movement that came from the cerebral cortex. The basal nuclei decide, no, this movement might not be enough to reach the glass of water, so please give me more power. Or else, if the cerebral cortex is giving a crude signal that is with a massive strength, that might lead to overshoot my hand beyond the glass of water, the basal ganglia reaches back to the cortex to inhibit this signal, causing the brain to initiate another proper signal, letting my hand reach for the glass of water and not beyond it. Also, through connection with the cerebellum, I'm controlling the muscle tone for the muscles needed to perform a function. I'm going to lift a glass of water weighing like 200 grams. Nothing, it's a small weight. So I don't have to have a huge muscle tone in my muscles to grab for this glass of water, or else I'll break it, okay? Whereas if I'm pulling or lifting a heavy weight, I have to have a large muscle tone to help me lift it from the ground. The one responsible for this muscle tone would be the cerebellum. Both the basal ganglia and the cerebellum regulate the strength of the initial signal, motor signal, plus the muscle tone needed to perform a smooth, purposeful movement. These structures modify and coordinate the movement so that they are performed in a smooth manner. It's not a clumsy movement. Information goes from the basal nuclei and the cerebellum back to the cerebral cortex to constantly monitor position and muscle tone. This is the circuit that we just talked about. My initial decision came from the primary motor cortex, premotor and supplementary motor cortex. This is the initial huge crude signal coming from the brain. The signal goes to the basal ganglia for replanning, goes to the cerebellum to adjust the muscle tone, and then back to the motor cortex one more time to precisely discharge an impulse that is equivalent to the intended movement. And this signal goes down through the brainstem and the spinal cord through the pyramidal tract to end upon the nuclei of the cranial nerves at the brainstem through the corticonuclear tract, or goes to the spinal cord through the corticospinal tract. The origin for these motor signals coming through the corticospinal tracts begins in the cerebral cortex, from which they receive a range of input, coming from the primary motor areas we just mentioned, premotor and supplementary motor areas. They also receive nerve fibers from the somatosensory areas. We said at the early beginning of this lecture that usually a motor signal is in response to a sensory input that has been integrated earlier. This area, or this somatosensory area, plays a role in regulating the activity of the ascending tracts. This is the whole picture. This is the whole interaction between the different body parts or different parts of the brain, between the cortex, basal ganglia, cerebellum, back to the cortex, and from the cortex to the spinal cord and to the brainstem. The pyramidal tract starts in the upper motor neurons in the cerebral cortex, with approximately up to 1 million neurons in number. The axons form the internal capsule in the cerebrum, inside the cerebral hemispheres, pyramids inside the medulla oblongata, descending axons of the upper motor neuron that terminate in the motor nuclei of the cranial nerves, and the spinal cord constitutes the corticonuclear and corticospinal tracts, as we earlier mentioned. The corticospinal tracts are particularly concerned with the control of voluntary, discrete, and skilled movements, especially at those of the distal parts of our limbs, meaning that the pyramidal tract is concerned with the movements of our hands and our fingers for discrete movements. The cells of origins are widely distributed in the motor and sensory cortices, including precentral gyrus and primary motor cortex. This is a diagrammatic representation for the pyramidal tract. As you see, we start our tracts from the cortical areas, the primary motor cortex. This is the primary motor cortex. This is the precentral gyrus. Supplementary premotor and supplementary motor are lying present just in front of it. The fibers coming from these areas are converging through the internal capsule, then through the brainstem, midbrain, pons, and medulla, till it reaches down for the spinal cord. The corticonuclear tract reaches the lower motor neurons of both sides, so it's bilaterally innervated, while the corticospinal fibers target the lower motor neurons only of the opposite side, so it's a crossed pathway, meaning that the cortical areas of the brain bombard both cranial nerve nuclei at the same time. If I'm having the right side of my cerebral hemisphere giving an order to a cranial nerve nucleus, it usually gives the order to both cranial nerve nuclei at both sides of the midline. I've got a nucleus for each cranial nerve on both sides of the midline. So if I'm talking about a corticonuclear tract, usually one cortical area bombards both nuclei for the cranial nerve nucleus. So it's bilaterally innervated from both sides of the cerebral hemispheres. And this is an advantage. So if one of the cortical areas present in one cerebral hemisphere had a damage from a stroke or anything, usually the cranial nerve is spared because of the bilateral innervation. It will have another intact motor signal coming from the other side of the cerebral cortex. Whereas for the corticospinal tract, it only crosses to the opposite side to reach for the lower motor neurons. So, if I'm having a damage to one cerebral hemisphere, the primary motor area at one cerebral hemisphere, this would cause a contralateral paralysis. Contralateral meaning that the paralysis will happen to the other side, the opposite side of the injury. If the patient is having a right-sided stroke, he would have a contralateral hemiplegia, meaning that he would have paralysis for the left side of his body, only the left side. Okay, whereas for the corticonuclear tracts, if I'm having a stroke to one side of the cerebral cortex, usually the cranial nerve nuclei are spared because of this bilateral innervation. For the corticospinal tracts, most of the fibers, 90% of them, crosses the midline, forming a motor decussation, descending in the lateral column of the spinal cord as lateral corticospinal tract, terminating on the lower motor neurons of the anterior gray column of all spinal levels. Whereas another part of the corticospinal tract, the 10% that did not cross with the 90%, form what we call uncrossed fibers, descending as anterior corticospinal tract. Eventually, they cross the midline and terminate in the lower motor neuron of anterior gray column of the respective spinal cord segment in cervical upper thoracic levels. So, the lateral corticospinal tract is represented in the whole length of the spinal cord, while for the anterior corticospinal tract, it's only represented in the cervical and the upper thoracic segment. One of them crosses, the 90% cross happens at the pyramidal decussation. This happens at the lower part of the medulla, whereas for the anterior corticospinal, it doesn't cross at the level of the brainstem, but crosses at the level of the spinal segment itself. So eventually both are crossed, but the level of crossing differ. The lateral corticospinal crosses at the lower medulla upward, whereas for the anterior corticospinal crosses at the level of the anterior of the spinal segment itself. The lateral corticospinal tract, the one distributed throughout the whole spinal cord, is responsible for the skeletal movements of the hand and feet, while the anterior corticospinal, the uncrossed one that is confined to the cervical and the upper thoracic region, is responsible for the control of neck and trunk muscles. Whereas for the corticobulbar or the corticonuclear tracts, they go from the cortex towards the nuclei, the cranial nerves, from the third cranial nerve till the 12th cranial nerve, and it's responsible for the movements of the eye, tongue, chewing, expression, and speech. This is the lateral corticospinal tract. This is the voluntary motor control coming from the primary motor cortical area. This is the primary motor area, area 4, supplementary motor and premotor and supplementary motor. The fibers coming from these areas converge through the internal capsule, then through the crus cerebri, the midbrain, the basal pons of the pons, then the pyramid of the medulla. At the lower part of the medulla, 90% of these fibers crosses to the opposite side and descends in the white column of the spinal cord, then reaching to the anterior horn cell of the specific segment required, present at the anterior horn of the gray matter of the spinal cord, and this is the anterior horn cell. And from this anterior horn cell goes the lower motor neuron till it reaches the effector organ. This is the beginning of the corticospinal tracts from the area 4 and 6, primary motor, premotor, and supplementary motor. The fibers, as we said, converge from all these areas to pass through the internal capsule towards the brainstem downward. At the midbrain, the crus cerebri, part of the brainstem, at the midbrain. This part passes through the pyramidal tract, the corticospinal tracts, then through the basis pons of the pons, and then at the lower part of the medulla. This is the pyramid of the medulla, this is the upper part of the medulla, and this is the lower part. This is the level of the pyramidal decussation, where the fibers crosses from one side to the other side, with 90% of the fibers crossing and 10% descending at the same side, named anterior corticospinal fibers. Then reaching to the specific descending spinal segment through the lateral white column, reaches to the lower motor neuron cell present at the anterior horn of the spinal segment, then reaches through the spinal nerve through the lower motor neuron lesion, reaching to the effector organ. To summarize, most of the corticospinal fibers cross in the decussation of the pyramid. A small portion descends at the same side ipsilaterally, descending in the lateral and anterior columns. This is the 90% with the crossing, and this is the 10% that descended without crossing. This is the anterior corticospinal. Both both are responsible for the innervation of the lower motor neuron fibers of the specific descending spinal segment. Many fibers in the anterior column eventually crosses in the spinal cord and innervate motor neurons in the contralateral ventral horn at the level of the spinal segment. As you see, it's here descending at the one side of the spinal cord and then crossing to the other side to innervate the cells present at the ventral horn of the spinal segment. So this is the lateral corticospinal and this is the anterior corticospinal. Another picture, the fibers coming from the motor cortex, the convergence through the internal capsule, passing through the brainstem. 90% form the lateral corticospinal, 10% forms the anterior corticospinal that eventually crosses at the level of the spinal segment. Another diagram with the same principles that we've been talking through the previous slides. Cortical areas, brainstem parts. This is the crus cerebri of the midbrain. This is the pons, and this is the medulla. At the lower part of the medulla, the crossing happens. This is the lateral corticospinal, and this is the anterior corticospinal that eventually crosses at the level of the spinal segment. For the corticobulbar tracts, the tracts arise from the lateral aspect of the primary motor cortex, like the corticospinal. They receive the same input as the corticospinal tracts. The fibers converge passed through the internal capsule towards the brainstem, also like the corticospinal tracts. The neurons terminates on the motor nuclei of the cranial nerves. Here they synapse with lower motor neurons, which carry the motor signals to the muscles of the face and neck. And as we said, that the fibers coming from one cerebral cortex is bilaterally represented on the nuclei of both sides of the cranial nerve. So if one side of the cerebral cortex is damaged, usually the cranial nerves are spared because the other side is working on both nuclei. This is a diagrammatic representation for the corticonuclear tract. As you see, it's coming from the motor cortex, like the corticospinal, passing through the internal capsule on the same way towards the brainstem. At this particular place, it starts distributing to cranial nerve nuclei present at both sides of the midline of the brainstem. I've got cranial nerve nuclei controlling each side of the body and at the sides of the midline. So as you see that the fibers are bilaterally supplying the cranial nerve nuclei on both sides of the brainstem. So if I'm having a problem with one cortex, the other cortex usually supplies both cranial nerve nuclei. So if I'm having a problem with one cortex, a stroke or something affecting the nuclei or the motor areas supplying these cranial nerve nuclei, it wouldn't be evident because the other side would be supplying both nuclei effectively, and I won't notice it upon my patient. The fibers terminates in several locations in the midbrain. The parts of the corticobulbar tract terminating in the midbrain is called corticomesencephalic tract. The part of the corticobulbar terminating at the pons is called corticopontine tract, and the part of the corticobulbar terminating on the medulla oblongata is called corticobulbar tract. The nerves within the corticobulbar tract are involved in movements of muscles of the head and neck, and they are involved in swallowing, phonation, and movement of the tongue. These are the fibers coming from the motor cortex through the internal capsule, distributing to the cranial nerve nuclei, as we just said. This is the corticobulbar tract. This is a summary for the pathway of the corticospinal tract. The sensory cortex gives like 40% of the initial impulse, primary cortex and supplementary cortex like 60%, pass it through the internal capsule, cerebral peduncle of the midbrain, pons, medullary pyramid, pyramidal decussation, lateral crossed and ventral uncrossed white matter in the spinal cord, anterior horn cells of the spinal cord through interconnections, and a motor neuron towards the opposite side. Again, this is a diagrammatic representation for the corticobulbar tracts. As we said, the part of the corticobulbar tract reaching the midbrain called corticomesencephalic. The one reaching the pons is called corticopontine, and the one reaching the medulla is called corticomedullary or corticobulbar. As you see that the fibers are crossing to reach the cranial nerve nuclei, even at the opposite side of the midline. Here I'm saying that the innervation happens to both sides of the cranial nerve nuclei, as we just mentioned and described earlier, and this is a more detailed picture for the bilateral presentation. The clinical significance for this corticospinal tract is that the fibers of the corticospinal tract, if they are damaged anywhere along their course from the cerebral cortex to the lower end of the spinal cord, this will give rise to a syndrome called an upper motor neuron syndrome or an upper motor neuron lesion. This happens when there is a damage to this corticospinal tract along its pathway within the central nervous system, not beyond the central nervous system. So the injury should be at the upper motor neuron that we earlier described. We said that the motor tract is formed of two neurons, an upper and a lower motor neuron. So if the damage happens between the cortex and the anterior horn cell, it's called an upper motor neuron syndrome. For the upper motor neurons, they are the fibers descending from the supraspinal pathways that influence the activity of the lower motor neurons. They control the voluntary motor activity, maintenance of posture equilibrium, muscle tone, and reflex activities. So if an injury happens to an upper motor neuron, I'm expecting a disturbance on all these functions, either an excitatory or an inhibitory disturbance. Upper motor neuron lesions results in damage of the multiple descending motor pathways. These motor pathways are either excitatory, like the ones linked to the pyramidal system, and others are inhibitory, related to the extrapyramidal system. We said that the pyramidal and the extrapyramidal system both work at the same time, and I cannot functionally separate them from each other. So both are working at the same time. An upper motor neuron lesion doesn't involve the pyramidal system only, it involves the pyramidal and the extrapyramidal system. So this injury reflects loss of the normal balance of excitatory and inhibitory inputs to the motor neurons in favor of increased excitability of spinal nerve reflexes. So in injury of the upper motor neuron type of lesion affecting anywhere in the central nervous system from the cortex till the anterior horn cell results in damaged upper motor neuron lesion, what we call a spastic paralysis. So what's the characters of the spastic paralysis? This paralysis is spastic, means that the person is rigid, is not flaccid. If you move his limb, you'll find the muscle tone present in this limb. He's not consciously controlling the limb. He's not moving it. He's paralyzed. But it's a spastic paralysis, meaning that his limb is fixed, somehow rigid, with the muscle tone. And this paralysis usually happens to the opposite side of the injury. So if I'm having a stroke to the right side of the cerebral hemisphere, I'm having an upper motor neuron spastic paralysis to the opposite side of the body, to the left side of the body. I have a loss of fine-skilled movement. Fine-skilled movement was one of the functions of the lateral corticospinal tract, responsible for the skilled movements present at the limbs. It would be lost. Increased muscle tone, because the disturbance that happens between the excitatory and the inhibitory function favors the activity of the excitatory part. So I can have an increased muscle tone that is reflected upon the paralysis to be a spastic paralysis with exaggerated reflexes. If I'm testing one of the reflexes at this patient, I'll see an exaggerated reflex. In addition to one particular sign that is very specific for upper motor neuron lesion, it's called Babinski sign. It's an extensor plantar response. It's a reflex that happens to the sole of the foot when I scratch the bottom of the foot or the sole of the foot with a hard object. Usually the toes are flexed towards the sole with plantar flexion. But in patients with upper motor neuron, I'll see that the toes are dorsally flexed, so they are fanning away from the proper reflex that should be present at this area. This is the Babinski sign. The proper Babinski sign, when I scratch the sole of the foot, I see a plantar flexion of these toes, meaning that these toes are flexed towards the bottom of the feet. While patients suffering from upper motor neuron paralysis have this very peculiar sign, the Babinski sign. When I scratch their sole, I'll see that there is fanning in the toes of the finger, in opposite to the normal reflex that might happen to the same person if he's not injured. So on testing, the big toe is dorsally flexed and the other toes fan outward on scratching of the sole of the foot. This is a very characteristic sign of upper motor neuron lesion. Whereas for the lower motor neurons, we just stated that the lower motor neuron is a neuron with the cell body within the central nervous system, while its periphery or the axon is outside the central nervous system, constituting either a spinal nerve or a cranial nerve. This lower motor neuron forms a final common pathway. This common pathway usually carries either a motor signal towards the effector organ or a sensory impulse coming from this effector organ towards the spinal segment. The lower motor neurons are constantly bombarded by nerve impulses, either excitatory or inhibitory, through the pyramidal or extrapyramidal system that descends from the cerebral cortex, pons, midbrain, and medulla. Lesions of motor neurons innervating the voluntary muscles or skeletal muscle at one of these sites constitutes what we call the lower motor neuron lesion. If the lesion happens at the anterior gray column of the spinal cord, the motor part of the spinal segment, the gray matter of the spinal segment, if a damage happens to the anterior gray column, usually the anterior horn cell that forms the lower motor neuron cell of the spinal segment is damaged with it. If I'm damaging a motor nuclei of the brainstem, motor nucleus of the brainstem, also a damage to this area would lead to what we call a lower motor neuron lesion. Or if the damage happens at one of the peripheral nerves coming off one of these cells, if it's a peripheral nerve coming from a spinal segment, a spinal nerve, or a cranial nerve coming from a cranial nerve nucleus. An injury happening anywhere beyond the anterior horn cell, the anterior gray matter of the spinal cord or the cranial nerve nuclei, is called a lower motor neuron paralysis. The characters for a lower motor neuron paralysis includes the following. We said that the upper motor neuron paralysis is named as a spastic paralysis. So there is a spasm in the muscles. It has a muscle tone. He's paralyzed. He cannot use his limb, but he has muscle tone and he has a contraction that is present constantly at the limb. Whereas for the lower motor neuron paralysis, it's a flaccid paralysis. There is no voluntary movement on the same side of the damage. The upper motor neuron usually happens to the opposite side of the body, whereas for the lower motor neuron damage or paralysis, usually the paralysis happens at the same side of the body. There is no reflexes at all. The muscle is limp and flaccid with no tone and decreased muscle tone with muscle wasting. If I'm not having a nervous impulse going to a muscle, the muscle will then waste and they will then atrophy. So patients suffering from lower motor neuron paralysis usually suffer from muscle wasting and their muscle starts to atrophy. So this is the difference between the upper and the lower motor neuron lesions. The strength of the paralysis, the reflexes, muscle tone, atrophy if it's present or not in the muscles, and other signs if are present or not. For the upper motor neuron lesion, we said that the strength of the paralysis, it causes weakness, paralysis, or paresis, and this happens in both upper and lower motor neuron. The patient is not able to move the affected limb. The reflexes in the upper motor neuron lesion is exaggerated, causing hyperreflexia, where at the lower motor neuron lesion, it's hyporeflexia. We don't have reflexes. Hyperreflexia or areflexia. We don't have any reflexes at this patient. The muscle tone is increased in upper motor neuron lesion, causing hypertonia with spasticity and hypotonia with flaccidity in lower motor neuron lesion, while I'm having a muscle tone reaching through the anterior horn cell towards the muscle itself. So I'm having a nerve impulse reaching the muscle, but it's not enough to its movement. So I'm having a minimal diffuse atrophy, whereas for the lower motor neuron lesion, I'm having atrophy for the muscle because I'm disrupting the motor or the nerve signal going to the muscle itself. Other signs present, I have fibrillations and fasciculations in lower motor neuron lesions, while I'm having extended plantar response or Babinski sign in upper motor neuron lesions. By the end of the lecture, I hope that you understood the concepts of the motor innervation and their pyramidal tract present at the nervous system. For any inquiries, for any questions, please feel free to contact me at any time. Thank you.